Good evening to each of you who have joined this important discussion made possible through the StreamYard platform and Facebook Live. I am Dr. Randall Morgan Jr., and I will be your host and moderator for this evening. I also serve as the president and CEO of the W. Montague Cobb Health Institute. The Cobb Institute was founded in December of 2004 at Howard University by the National Medical Association to pursue solutions of health disparities through scholarly discovery of key drivers of those disparities and the data collection necessary to support those solutions. Since 2008, the Institute has been a 501c3 nonprofit organization separate from the National Medical Association, but remains strategic partner of the NMA through most of our programs and initiatives. Our host on this program this evening is blackdoctor.org, an important organization that is also 20 years old and currently the world's largest and most comprehensive online resource specifically targeted to African Americans and their collective culture. The Cobb Institute and blackdoctor.org have collaborated to produce this webinar series for almost 2 years on a monthly basis. This evening, we welcome two distinguished physicians who are both cardiologists, physician scientists, world-class academic leaders, representing two of our well-known historically Black colleges of medicine, who will inform us of the state of heart health in our communities and the world through the context of Black History Month and Heart Health Month as well. I'm honored to introduce our speakers this evening. Dr. Elizabeth Ofili is professor of medicine and cardiology and the director and senior associate dean of clinical research at the Morehouse School of Medicine in Atlanta, Georgia. She is also the contact principal investigator for the Coordination and Evaluation Center. She is a principal investigator for RCMI Coordinating Center, and she is a global principal investigator for the African American Heart Study sponsored by Amgen. Dr. Quinn Capers is the professor of medicine and the current chair of the Department of Medicine and also chair of cardiology at Howard University College of Medicine. He has just completed his first year of service at Howard University. Dr. Capers has been widely decorated as an educator, clinician, and champion of diversity enhancement in medicine. He is a graduate of Howard University's College of Arts and Sciences and the Ohio State University College of Medicine. He trained in internal medicine and cardiovascular diseases and interventional cardiology at Emory University. He has spent time in private practice and held faculty positions at Vanderbilt University, Meharry Medical College, the Ohio State University, and the University of Texas Southwestern Medical Center just before joining Howard University as a tenured professor. Welcome, Drs. Ofili and Dr. Capers.
Thank you so much, Dr. Morgan.
Thank you.
Thank you. So, in a report released on January 27th, 2025, in a publication entitled Circulation, which is the flagship journal of the American Heart Association, the highlights were as follows. Number one, heart disease remains the leading cause of death in the United States today. Two, many of the risk factors which lead to these diseases, including high blood pressure, continue to grow at an alarming rate. And three, cardiovascular diseases, including heart disease and stroke, claim more lives in the United States than all forms of cancer and accidental deaths combined. Therefore, there is no topic related to healthcare at this time that is of greater importance to each of us than heart health. Let us begin our discussions. Dr. Ofili, could you explain how the current status of heart disease globally impacts the treatment of heart disease in the United States? Is there a relationship?
Thank you so much, Dr. Morgan, and welcome to our audience. And thanks for the opportunity to share some remarks here. As you stated, and definitely the American Heart Association, the American College of Cardiology, the World Heart Federation, everyone acknowledges that we are not winning the battle against heart disease. And part of the problem is just the growing prevalence of multiple chronic health conditions such as high blood pressure, high cholesterol, diabetes, obesity. One thing we've learned over the years is that heart disease remains the #1 killer, and that is so for the United States as well as outside the United States, especially if you're looking at adults. The other thing we understand now as research becomes more focused is while there are obviously some genetic predispositions, the vast majority of the risk for heart disease are preventable. And that we put in that bucket high blood pressure, cigarette smoking, diabetes, obesity, lack of physical activity. And so organizations like the American Heart Association, as well as the Association of Black Cardiologists, have begun to look at ways to actually group these risks so individuals can begin to not just personalize their risk, but understand how to more properly manage for the long term. As you know, the Association of Black Cardiologists is now in its 50th year, and we are very proud for 50 years of work, both here in the United States, and we remain very much dedicated and committed to advancing health and cardiovascular prevention across all groups with strong focus on underrepresented individuals, especially Blacks. What we have continued to promote, and again, I am proud as a past president of the Association of Black Cardiologists, as well as a past chair of the board, that the ABC, as we call the Association of Black Cardiologists, has worked not just across all of the United States in various communities through its programs such as Spirit of the Heart, where we're right there in the communities working with our physicians who are in practice in these communities to begin to address these growing disparities in cardiovascular outcomes. And we are proud for partners. And as we went with the global question that you asked, we have partnered with cardiologists in sub-Saharan Africa, especially, to focus on the condition, because now we know that there is growing prevalence of high blood pressure, there is growing prevalence of obesity and diabetes, and of course, these directly lead to cardiovascular disease, including heart attacks and strokes. So I believe they're definitely interconnected. The more we learn about heart disease in the United States and in sub-Saharan Africa, the more we understand what has to be done very much to control the social determinants of these conditions, but also continue to emphasize the gains we've made as we've advanced access to care and good quality care. Thank you.
Thank you, Dr. Ofili. Dr. Capers, would you like to comment on the globalization of heart disease and the care thereof?
Sure. So first of all, good evening to everybody. It's an honor to be on a panel with my wonderful colleagues, Dr. Ofili and Dr. Morgan. And I share Dr. Ofili's pride in the Association of Black Cardiologists, and just being here with you is very special. So the treatment of heart disease is so important. This is unfortunately the scourge not only of Western society, but of the world. But it's a good time to be a cardiologist. It's a good time to be caring for people who suffer from heart disease. If we take two of the most common problems that cardiologists deal with, congestive heart failure and coronary artery disease, we're really in a wonderful time right now. If we start with congestive heart failure, especially, just when we thought for at least a decade that we couldn't get any better in terms of medication that prolongs the life in patients with a weak heart, congestive heart failure, and reduces hospitalization, we recently have had additional classes of medication that appear to improve upon what we have already had. And so now we'll often hear people talk about in medicine the four pillars of treatment for congestive heart failure. And so we've got beta blockers, we have medicines that inhibit the renin-angiotensin system. We've got kind of a newer class of medicine that was originally invented because we thought it would help with diabetes, and it does a little bit, but it turns out it helps a lot more with heart disease, even in people who don't have diabetes. And those are what we call the flozins, or SGLT2 inhibitors. And then blocking the effect of mineralocorticoid, aldosterone, on the heart really has been shown to improve outcomes, reduce hospitalizations, and prolong life. So people who suffer from congestive heart failure, especially from a weak heart, we have wonderful tools to treat it. Now, the issue is the cost of those medications and being able to get them, and those medications being used in an ethical and equitable manner. Coronary artery disease, we have ways to prevent it, and Dr. Ofili pointed out how so much of this burden of heart disease comes from a burden, an excess burden of these risk factors, the things that put you at risk for heart disease. And one of those, so important, is an elevated blood cholesterol. So the fats that circulate in the bloodstream deposit inside of the arteries, and then you're off to the races to have blockages in your blood vessels, in your neck, in your brain, in your heart, in your legs. Well, one wonderful way to prevent bad outcomes in those patients is to put them on cholesterol lowering medicines. And we have a group of medicines called statins that have done a terrific job, not only in preventing second heart attacks in people who've already had heart attacks, but in preventing that first heart attack. And that's so important. So wonderful treatments for congestive heart failure, wonderful treatments in reducing cholesterol and improving outcomes in people with coronary artery disease. By trade, I'm an interventional cardiologist, so opening blocked arteries with balloons, stents, lasers, and other things. We are truly able to do some incredible things. And now my subspecialty, interventional cardiology, has grown to expand what can be treated with catheters in the heart. Now we can fix heart valves, we can fix holes in the heart, we can repair leaking valves. And so I like to say it's a good time to be a cardiologist because we have wonderful tools, both devices and medications. The problem, and I know we're going to talk about this, is having that wonderful technology applied in an equitable manner. And we still are not there, and we still have healthcare disparities right along racial lines. So we've got a lot of work to do there. But in terms of treating heart disease and even preventing heart disease, which is just as important, Dr. Ofili pointed out very well, we have an excess of obesity, not enough exercise, cigarette smoking, high blood pressure, diabetes. And we know that if we prevent those things, we get you to stop smoking and we get you to move more, we can reduce the incidence of heart disease. So we've got wonderful treatments once heart disease develops, but we all need to work harder and harder to get our patients to do the very best they can at preventing heart disease. And a lot of that is societal as well. So some of the ravages of societal racism with segregated housing, with people of color being segregated in neighborhoods with worse air quality, worse water quality, et cetera, being over-policed, being, the schools being less well-funded. Those things add to these excess risk factors. So it's not just about patients having willpower. I always make sure my students know that. It's not that this patient didn't have willpower and doesn't know that they should exercise and they shouldn't smoke, but society plays a role in this kind of societal structural racism can add to this excess disparity that we see in communities of color. But a good time to be a cardiologist and to be on a panel with wonderful colleagues like you two, and to want to help all people.
So I'm fascinated by the work that's being done by ABC and others globally. And so with these techniques, with these medications that are often expensive. How are we helping to disseminate those methods of treatment on a global basis? Do we have partners on the pharmaceutical side or the philanthropic side that are helping to make a difference? What do you see as maybe strategies for the future in terms of how we can influence those across the globe who are having the same difficulties?
Well, so as far as the procedures, we really need to try to be a little more systematic and work with governments and hospital systems overseas. And a lot of it is about resources. But what we are doing now, and ABC has been a leader in this along with other organizations, about exporting technology in the other direction. So ABC has sponsored groups of cardiologists to go to sub-Saharan Africa and perform some of these procedures, pacemakers, cardiac catheterizations, stents, and even in some cases, in reverse, to bring patients to the United States who need specialized heart surgeries. So those are things that groups of people can do together, sponsored by the ABC, sponsored by other organizations. But if we're talking about a whole population, it's going to take more than that. And it's going to take working and partnering with governments and organizations, and especially philanthropic organizations. So I'll see if Dr. Ofili has something to say about medications and some other treatments globally.
Yeah, so thank you. So I actually just wanted to just step back a little bit and in terms of how ABC's addressing some of these. So for example, ABC has run for many years a fellowship program, and we know that's within the United States. So as a way to address some of the problems with access, several of our young physicians, as they graduate from various cardiology programs, get extra training, like Dr. Capers is trained in interventional cardiology, in electrophysiology. ABC partners with industry to support these very, very intelligent and very hardworking physicians. And they are now they are now actually working in many underserved communities to deliver much needed care. We're applying the same thing internationally. So in sub-Saharan Africa, as we partner with the Nigerian Cardiac Society, for example, they're sending some of their doctors to participate in ABC sessions. And I think that leads us to the next phase of actually expanding sponsorship in collaboration with these health systems locally. I want to say, Dr. Morgan, as well as Dr. Capers, as you all know, there are obviously many, and Dr. Capers, you spoke to this, many wonderful drugs being developed. One of the challenges we have as a community, cardiovascular community, general medical community, surgical community, is that a lot of the drugs and devices and various procedures are being tested in individuals that are not of African descent. Now, we know from research that individuals have varying ways that they respond to treatment, whether it's a drug or a device, and having the vast majority of individuals that will utilize that product be a part of the clinical trial is important. And I just want to mention that obviously both the Cobb Institute, the Association of Black Cardiologists, Morehouse School of Medicine, Howard University, all of our institutions have been working over the years to expand access to research and clinical trials that's ethically designed and ethically implemented. And we actually have to continue to talk about this to members of our community, because if we're not part of the design of these studies, then it's hard to understand how we would react to the treatment when it's available to be utilized. And then finally, I know we'll come around to this, as you say, Dr. Capers, as well as Dr. Morgan, in thinking through about the whole discussion around health equity. We need to understand how that intersects with health literacy. Our knowledge about our own bodies is critical for us to actually get help from our doctors. A lot of the times, traditionally, patients expect doctors to tell them everything. When you talk to millennials now, and I have about 4 of them as my kids, They want to go to the doctor armed with a lot of information. And even some of my older patients would ask me, what do I need to know? What can I do to help myself? So I want us to talk about that as we have this conversation, because there's a lot that patients can do armed with the proper knowledge.
Yes, and actually, one of the potential collaborations for the Cobb Institute and the National Medical Association in Africa and Sub-Saharan Africa is actually working to provide educational information in many languages facilitated by AI. And so that's just a fascinating way. But of course, people have to have a chance to have some sense of understanding what is going on with their health care, and things are so complicated these days that even those who are intelligent, by the time you have the stresses of being there in front of the doctor or seeing your own test results, it kind of compromises your ability to reason and learn. So you've got to take your family along. Well, this is wonderful. I think our discussion about the globalization and the one that subsequently followed in terms of the treatment of heart disease is, I think we've covered many of the topics. I did want to ask about the precision medicine genomics side of things in terms of new medication development. Is that an important part of the cardiovascular disease medications as well?
Absolutely. I can,
yeah, please.
yeah. I was going to start from the standpoint of actually medication, how we understand now genome medicine, as well as the interaction of gene environment. So, for example, you mentioned the introduction that I'm global principal investigator of the African American Heart Study. So this is about lipoprotein A. It's called lipoprotein little a. It's a kind of lipoprotein that is just as atherogenic as what we call bad cholesterol or LDL cholesterol. What we have learned over the years is that it does advance and increase the risk of premature cardiovascular disease, heart attacks, and strokes. But a lot of that work has been done in European people of European ancestry. Very few work has been done or research has been done on African Americans. And we understand now that many African Americans have higher levels of LP little a. Just full disclosure, I am one of those. I have high levels of LPA. But the problem has been we don't understand how does it affect us, and also is there value in medical treatment specifically targeting LP little a. I'm very, very proud that a company like Amgen has sponsored this 5,000 patient African American heart study, because now we're getting to the end of enrollment of those 5,000 patients and learning a lot about lipoprotein A from the standpoint of the genomics of that. But importantly, as we look to opportunities for medications to come on the stage, I think we now can understand how would these potential treatments going forward benefit everybody, including African Americans who happen to be at higher risk given the higher levels of lipoprotein little a. I know there are other areas of genomics. Morehouse School of Medicine is very much involved with a large genomics cancer program with other HBCUs working within sub-Saharan Africa. So there's a whole really movement to understand these interactions, because treatment can be targeted, as you mentioned, Dr. Morgan, from a standpoint of a precision medicine, understanding what the gene targets are, as we're learning more about gene targets for various kinds of treatments, including cancer and cardiovascular disease. And I know, Dr. Capers, you were going to comment as well.
Yes, I was essentially going to say that a couple of things. One example of just how important this genomic medicine and precision medicine and personalized medicine can be. is what we've learned in cardiology, for instance, about the way an individual body processes medications. So in interventional cardiology, we open up these blocked arteries and we put in a stent, which is, made of, initially they were stainless steel. Now there's some alloy of metal. Well, your bloodstream isn't used to having metal in it. So immediately your bloodstream will want to clot on that piece of metal. Well, we prevent that with giving blood thinners. But one of the important classes of blood thinners actually needs your body, the enzymes made in your liver, to convert it to its active form. Well, that's under genetic control. And we found out after certain populations were clotting off their stents more than others, that not everybody has a functional form of this enzyme. And so we now can test for that. So in a patient that's going to get a stent, we can test to see what form of this enzyme they have. And that can help us decide, do we need to just treat them with the strongest blood thinners we have, which can put people at risk for bleeding, or can we do a less potent blood thinner in them? Just one example of the importance of understanding genomics and not one size fits all. For so long, and still, it works okay most of the time, but in medicine, we have kind of with drugs, a one size fits all.
Yeah.
Like we give everybody a beta blocker, but we've all known for a long time that you can give 100 people in the room the same dose of a beta blocker. Some of them, it will reduce their heart rate a little bit. Some of them, it'll reduce their heart rate so much that they faint. And some it won't affect at all. That's because our different bodies are different. So this human variation is a beautiful thing, but in precision medicine, we've got to understand a little bit more, and we can refine what we do. The other thing I want to say about personalized medicine is that while we often think of genomics when we talk about personalized medicine, it can go beyond genomics, and it can go to culture and style and lifestyle as well. So that's very important, but getting beyond one size fits all, which again works very well most of the time, to precision medicine. So we're treating families and individuals a little bit differently based on what the science tells us is very exciting.
Now, with the studies that you both are mentioning, are most of the cohorts for these studies African Americans or Africans, individuals of African descent who are in the United States, or are they actually, global as well? The Caribbean, Sub-Saharan Africa, and so forth.
Yeah.
How does it stack up?
Yeah, so I can just talk a little bit. The African American Heart Study is specific to the United States.
Yeah.
And it's people of African descent, but they have to be here in the United States. And I think it's just the first step. What happens with global research is there has to be multiple controls, right? You've got to be very clear about the institutional review board, which is how protocols that are approved are implemented. And my understanding, again, as I discuss this with sponsors, is they are very eager to eventually have, studies across the globe. There are many studies currently that NIH funds, a National Institute of Health, in the Caribbean as well as in Africa. But the drug trials, because of the multiple controls that are required, are just getting underway, and there are many, many opportunities to do that. So, Dr. Morgan, I just want to pivot a little bit to sort of pull in what Dr. Capers mentioned earlier about the question of lifestyle, and hopefully I'm not getting ahead of us, but
No, we're right on target.
Great. To me, it has really been fascinating to understand what happens with the gut microbiome. And so when Dr. Capers says the personalized medicine is also about lifestyle, I have really been, over the last 7 or 8, now almost 10 years, looking at what happens with inflammation based on what's going on in all of us. We have just these trillions of bacteria, And many people have discussed this because, you do have the probiotics, the prebiotics, and how that alters the gut microbiome. I have learned now, especially just because the general media is really fascinated with it, but diving deep down to understand that each of us, when we're born, we have these sets of diversity of microbiome or the microbiota. And it turns out that it's actually different if you're born, transvaginally versus C-section, because exiting transvaginally gives you access to more bacteria, whether a child is breastfed or given milk. So the environment is that whole gene environment interaction that begins to emphasize our own individual gut microbiota. Most importantly, what happens with our diet, and they've now studied people who've gone from rural communities to more urban settings with more, dairy products or meat in the diet, there's a change in the microbiota. Unfortunately, a lot of this change is going in the negative direction. And a lot of that is driving cardiovascular disease and obesity. So one of the things that I'm hoping we begin to focus on, and again, the media is carrying a lot of this to say that gut feeling, that was one of the headlines I saw recently, talking specifically about the conglomerate of inflammation and the interconnectivity between cardiovascular disease. I know we're talking about Heart Month, but it turns out that when you look at chronic diseases, what connects all of them happens to be inflammation. And the fact that these gut bacteria can either promote inflammation or reduce inflammation is absolutely fascinating. And that research is now moving to say, is it possible to change people's gut microbiota? Some people are looking at opportunities with, for example, bypass, intestinal bypass to treat obesity does alter the gut microbiota. But the most important way to alter it is with diet. There's been lots of studies done. A lot of that is not as well publicized. But I think as we discuss health equity, many of my patients are very interested in what they can do to help themselves. We really need to be emphasizing this opportunity to understand our own individual gut microbiome and what we can do to help us have healthy gut microbiota. So I'm going to get off of my stage because I just get excited when I talk about that.
Well, thank you for bringing that up. And I knew that the longer we talk, the more educated I would be. And just when you think you know a little bit, then you find out that you really don't know, and you're right back to go again, trying to start. Dr. Capers, what are your thoughts about the general inflammatory milieu, I guess?
Yes, well, I couldn't agree more with Dr. O'Feely. Inflammation is certainly now I'm much more familiar with inflammation in vascular disease and cardiac disease, where it really appears to be the root of all evil. I mean, all of these things that attack the blood vessels and make the blood vessels less healthy are in some way mediated by inflammation. Elevated blood sugars, elevated cholesterol, these things cause inflammation. And so anti-inflammatory, the search goes on for anti-inflammatory diet or drugs that we can take to reduce inflammation globally. We haven't found a silver bullet yet, and the silver bullet may just be in diet. And so we are learning more and more about that. I was at a fascinating talk here at Grand Rounds at Howard not too long ago, and it was our chief wellness officer that was talking about the importance of diet, and they really pointed out something that points out what we can do better in medical education, because he was saying that where medical school curricula, at least the United States, really fall short is in nutrition and diet and food as medicine. And I remember it was a long time ago when I went to medical school. I even remember our lecturer when I was a second-year medical student talking about nutrition. She said, "This is the only hour you're going to get. We got 1 hour. In 4 years of medical school, we got 1 hour lecture on nutrition." I hope it's better than that now, but it still is probably not as much as it should be.
Absolutely. And I think that's why the team-based approach now matters, because nutritionists have known these for a long time, but doctors have not. And now in partnership, they have this. I'm glad you mentioned the food as medicine approach, but I think obviously there's going to be gradations. If you have heart failure, as Dr. Capers just mentioned, if you've had a heart attack, there are diets that would help, but now we're talking about a need to look specifically at medications and the kinds of interventions that Dr. Capers has described. So the good news, as Dr. Capers said about cardiology, we have the whole span of it, from prevention to even when you have the condition, having an opportunity to potentially so improve the condition. It's not a full reversal, but it's as good as it gets, as close as it gets to a full reversal. That requires a partnership with your healthcare team. You coming to the table with some of what you know about your body, but also being willing to provide some assessments. Because what happens to your blood pressure when you're at home for 8, 10, 12, 24 hours versus when you're in your doctor's office for 15, 20 minutes? It matters. And now we're focused on this personalized approach where we're using as much of your information that you've gathered and hopefully documented, so your physician and cardiologist will be able to treat you better.
I think one other point that I'd like you to comment on, just for completeness, I'm sure there are many in the audience who are grappling with the use of medications specifically to lose weight, and the treatment of hypertension, and kind of where are we on that? Because it seems like a lot of people are self-medicating, and they're dancing across the television screens now with all of the commercials, and where is good medicine in, and frivolity begin?
Yeah. I mean, I can start. Obviously, I wear the badge as a preventive cardiologist. And by that, we mean there are reasons, and again, we've talked about this, to be on treatment. So high blood pressure, we know, is the commonest cardiovascular condition, cardiovascular risk in sub-Saharan Africa, in the United States, globally. When we have high blood pressure, there is a genetic component to it, but there's also a lot of environmental things. So we eating diet that's too high in salt, processed foods. A lot of processed foods have preservatives. So I always say to my patients, we can discuss how you want to manage or be a part of this treatment. Some patients go, doctor, I don't want to be on medicines. There are some times when you have to be on medication, because if you have had a family history, people from your family have either had strokes, heart attacks, been on dialysis, that's telling you something. There is a predisposition there. Mm-hmm. The next thing is to say, when we prescribe the medication, what works for you? As Dr. Capers said earlier, sometimes there's some personalization that's required, but we generally have a group of drugs that we know work. So when that's prescribed, though, rather than decide, well, I'm not going to take this because it makes me go to the bathroom. I don't want to go to the bathroom. I'm going to see my neighbor. I don't want to have to stop. Well, when you do that, the blood pressure that's out of control is out of control for 24 hours. So these medicines are designed to work with your body, with your physiology. So what I say to my patient is, if you're going to change the time you're taking it, be sure you're measuring your blood pressure and documenting it so your doctor can see, because it may be that they can switch it. Instead of you taking it in the morning, maybe you can take it in the evening or late afternoon. The bottom line is, there are so many drugs that work well. And yes, I agree with you, Dr. Morgan. There are people dancing across the TV. Sometimes that's flashy and that's looks good, sounds good, but be sure that whatever they're selling applies to you. You have to talk to your doctor, or your healthcare provider, I should say, Be willing to monitor yourself so you know what's working for you, but don't start self-medicating because somebody can compound a drug and then all of a sudden you're using it. I know we haven't talked about weight loss medicines yet. I think everybody's going, well, didn't they ask about weight loss earlier? Go ahead, you take it, Dr. K first.
Yes, yes. Well, so you know what I'm sitting here thinking about is when gastric bypass surgery first came out, weight loss surgery to bypass the stomach or to do some things to reduce the size of the stomach and the weight loss that it got. There was stigma at first, and I'm sure you'll remember at first there were some celebrities and maybe others who they hid the fact that they had that gastric bypass surgery.
Yeah.
They were embarrassed. There was a stigma attached to it. And then as time went on, we saw people have this surgery who had diabetes and their diabetes went away when they lost weight. They were taking 3 medicines for high blood pressure. Now they're only taking 1 medicine for high blood pressure. And the data shows that they live longer. Now we have these medications that can alter some of the hormones in your body and help you to not have an appetite and lose weight that way. It is starting to look like there are healthy ways to lose weight. And it's not all about, we need to get past the stigma. It's not all about willpower, right? So, you know, I used to hate when people say, oh, you want to lose weight? Just do push-aways, push away from the table. Well, that doesn't work for everybody. It works for some people, but it doesn't work for everybody. And I think we're getting to the point where we're learning, you know, any weight loss, as long as it's not something dramatic that's harming you, is good weight loss. It's good for your heart. It's good for your blood vessels. It's good for your blood sugar. But Dr. Ofili and Dr. Morgan are right. Please consult your doctor. There have always been a lot of people around who are so-called experts. Everybody's got a cousin that says, I know how you can treat this, or a neighbor says, I know how you can treat this. Take that information, please, to your doctor that you trust.
Yeah. And I think, Dr. Capers, to Dr. Morgan's earlier questions, I think the GLP agonists, various weight loss drugs are now in vogue, and we see the results. People are losing weight. People are getting healthier. Diabetes improving, obviously cardiovascular disease. So there's a lot of research going on around that right now. And I would just encourage our listeners to, you know, talk with your physician. Again, don't just go get on a drug on your own, because some of these drugs do have side effects. They're well tolerated overall, but there's still side effects like pancreatitis. Even though it's rare, it can happen. So be sure you're doing this under the care of a physician so they can select what's right for you. And there are a number of them out there. I mean, I have patients with congestive heart failure who've struggled with obesity for a long time. And as you just mentioned, Dr. Capers, it's not just about willpower, because there's some of the what we call social determinants of health, you know, and then there are these gene environment, interactions that predispose to obesity. And so now everybody recognizes that sometimes some people don't even diet. They lose weight. Others diet as much as they can. They cannot keep the weight off. So it's just important now to recognize that we know more about the root causes of these conditions. It's not just about willpower, but getting help and making sure you're being treated by somebody who's properly qualified, and not just someone who can just dispense a drug because they could compound it, because then you're not getting monitored, and that's not safe.
Thank you. So, Dr. Capers, you've been an academic leader in cardiology and also an admissions director at medical school at a large, predominantly white institution during your earlier career. From your perspective as the chief of medicine at an iconic, historically Black college of medicine, what is the importance of the Association of Black Cardiologists in filling the gaps in terms of the needs that we have for new cardiologists?
Well, the Association of Black Cardiologists is tremendously important. It certainly was when it first started, with the very few. I mean, even now we know that less than 3% of cardiologists are Black or African American. So when it started, amongst its founding principles was we need more. We know that more Black cardiologists will improve not only the healthcare of minority communities, but really of all communities. And Black physicians, Black students, Black pre-med students who want to be cardiologists really can look to ABC as a beacon, look to a group of people and think to themselves, these people look just like the people I grew up with. They look like my favorite uncle. They look like my mother. They look like my father, and they can do it. That means I can do it too. So as a source of inspiration, as a source of medical care for underserved communities, as a source for scientific statements that really helps to guide what we do. We can't, I know we're almost at the end of Black History Month, but this is some real good Black history for you. The Association of Black Cardiologists and what the legends who started the organization, and I would count Dr. Ofili as one of those legends. It's just, you can't say enough about ABC.
Well, certainly I can't. I'll tell you just personal story is had the opportunity many years ago to be the president of the National Medical Association. And so one day you're not the president, and the next day you're the president and you're the expert of 26 subspecialties. And you're able to answer any question about any type of medical problem. And I had a hotline between ABC and my office, because 80% of the questions had to do with cardiology. And I had such positive responses and great relationships with members of ABC who not only would, give me a quick update, but also speak or write or represent the association in any way that's necessary. And I think we need more. We need more cardiologists. We need more than 3%, because this is the biggest killer that we have. We have 3% orthopedic surgeons or 2%, whatever it is. So most of our subspecialties that are so important are so small in terms of our representation of physicians of African descent. And so I hope that ABC can stimulate other young physicians to be cardiologists, because as I see the importance of having cardiologists in every community and cardiologists who understand the culture of our population, I think it's key, and we need to figure out ways to expand your, and when I say you, I mean all of you who are members of ABC, the capabilities that you have to influence good health in the United States.
Absolutely. And I think I would add our listeners, viewers, to visit abcardio.org. That's the website of the Association of Black Cardiologists. You're going to find a lot of information. They go to various cities with various what they call Spirit of the Heart programs, working with local community leaders, cardiologists, as well as community health workers in the community for the subject at hand in terms of early education around introducing cardiovascular education early enough and encouraging people both from elementary to middle school to college. ABC does, as part of its meeting, partner with some local HBCUs as well as other institutions to conduct various kinds of outreach and educational opportunities, just so people can learn about medicine, about cardiology. And again, as you say, Dr. Capers has done a lot of this work through his many affiliations with big institutions. And now also, I'm so proud of you, Dr. Capers, for the work you have started at Howard. And I know you're going to do amazing work there.
Thank you. Thank you, Dr. Ofili.
Yes. Any comments, Dr. Capers, or things that in our discussion may have popped up in your mind?
Well, just in my mind, I think I would just say as these kind of closing comments, these can be difficult times for people like the three of us who truly believe that diversity and racial justice is important, and it's necessary, and we've dedicated a portion of our career and our lives to it. these can be difficult times, but what I'd like to say to the audience is it's a part of our makeup that we triumph in difficult times. The way we do it, though, is by working together and keeping our eyes on excellence and supporting each other. There may be days when you are not feeling as up as usual. Look to your brother and your sister to lift you up, and then you do the same when somebody needs to be lifted up. But we know we need more diversity, equity, and inclusion, even though some try to make those bad words. We keep fighting the good fight. We lean on each other. We will prevail like our people have every time they've come up against hard times.
Absolutely. Dr. Ofili.
Yeah. I mean, I would echo what Dr. Keeper said. I think that the North Star here is an opportunity to make an impact. And that impact is around health inequities. There are health disparities. That is documented, tons of papers around it. But we also know that it is possible to improve that. It's multi-layered, as we just shared. Obviously, it can't just be the doctor alone. It's a community that we live in. It's the social determinants that are around us. And so it's going to continue to be, obviously, there are the policies around that we all will continue to advocate for. But I couldn't agree more than what you both shared around community. I think that at the end of the day, just knowing that we're fighting the good fight, the fact that we can combine all of our efforts together instead of fighting separate fights, I think that's where the win is. And we're already winning. I just think we have to power through this one. It's pretty heavy for all of us. But at the same time, we're looking at some bright lights. We're looking at many, many bright young people who have interest in medicine, who have interest in science. And we have to continue to encourage young people to find allies and partner. There are many, many communities that are still doing this good work. So don't be discouraged. And then I think, have to always come back to our own personal health. How are we holding up? How are we doing self-care? What do we need help with? I think we have to be healthy to be able to help our community.
Mm-hmm.
Absolutely. The tension that many young medical students and residents are feeling now in terms of where they're going to end up and how successful they're going to be, and all of the barriers that exist, and even in trying to complete their training. I think these types of pep talks help, because you have to begin to see yourself as a part of the solution.
Yeah.
And not just a student, that's sort of on this treadmill.
Yeah.
But that you actually have a place, and you have an essential place, and no one can take that away from you based on definitions or someone's definitions of disparities, inequities, DEI, et cetera, et cetera. And so hopefully these types of discussions, and we'll share this conversation with any of the medical students who are interested. Mm-hmm. I think it would be very enlightening for them and give them courage.
That's great. Mm-hmm. Thank you.
So I can't thank both of you enough. Obviously, I worked very closely with both, and so it was kind of like I had two ringers. I knew who the experts were, and so but you performed even better than I thought that you might. And again, it's encouraging for all of us that are practicing medicine to see our colleagues and the the honors that they have received, the work that they're doing, and particularly internationally. So I think beginning the program and ending the program with the consciousness that we have something to give to the world is extremely important. So we'll go about our work and do the best that we can. I'd like to thank BDO for supporting us, for allowing us to bring these scientific experts to the table at any time. If there are topics that you think of, Doctors Capers and Ophelia, in the future, please bring them to us, because we do have this option of, sort of just-in-time information if it's important for our community.
Thank
I
you.
think, I think that's all that I would like to say. We look forward to the next time to get together and have these discussions. I'm sure we'll see each other in Chicago, the National Medical Association, in July, if not before. Audience, thank you very much for sharing. And one other thing, there is a QR code that will allow you to see the full bios of these impressive scholars. These are world-class scholars. And want to make sure you know all the accomplishments of Doctors Capers and Ophelia. And also, if you have questions, please share them in the chat, and we will share them with the appropriate speaker.
Mm-hmm.
So thank you very much, and have a good evening.
Thank you, Dr. Morgan.
Good night.
Bye.